Hi, thank you everyone for coming to join us today for this presentation on osteoporosis from Dr. Colin Gundling. Thank you, Dr. Gundling, for joining us again. And with that, I think I will hand things off to you. Just as a reminder, if you have questions during the presentation, you can put them in the chat function at any time, and we will get to those questions either at the end or when they fit into the presentation. Thank you.
All right, great. Well, I appreciate it. Thanks for having me again. I'm excited to be able to dive into this topic. As I was putting this talk together, I realized that it's a few different topics that we've kind of covered throughout this series at different times, kind of brought into under the specific picture of osteoporosis, which is oftentimes easily expanded to falls and fractures. So it comes into balance, it comes into strengthening, exercise, all those things come into play. So this is coming at it from a specific guise of osteoporosis, but you'll see some similarities if you've watched any of the other recordings here. So hopefully it's not too boring. But the focus here of this talk initially is going to be just giving you guys a view of the background, the initial background of osteoporosis. And I'm sorry, I had some nice pictures in this Word document, but for some reason, when I brought them off of the cloud, the pictures disappeared and I didn't have time to put them back in. But hopefully I'll explain them for you a little bit. So the first thing to consider is with hip fractures, oftentimes we talk about what happens first. Did the fracture happen as a result of the fall, or did the fall happen as a result of the fracture? So it's a kind of classic chicken or the egg scenario where where it might seem obvious to you at first without thinking about it that of course that fracture happened as a result of the fall on the hip. But oftentimes it's not that clear. And we can actually see from some other research that's been done in osteoporotic individuals that it doesn't take much pressure to cause a fracture. So it could certainly be that the fracture occurs, which results in the fall of that individual. So it's not super clear, but the biggest thing to be aware of here is that, we talk a lot about decreasing your risk for falls by training your balance, training different systems, and making you more aware of that. But we could do all of that stuff really well. And if you don't have good control over your bone mineral density, then you could still fracture your hip and fall. So there's more to it than just controlling your balance. In these cases, there's the consideration for what's going on at that bone level. So osteoporosis is something that's brought up often amongst individuals that are getting older, especially, or with significant comorbid conditions. Sustained use of steroids, oral steroids and things can increase your risk for it. But the real key to understand is that starting with more bone mineral density is better. So unfortunately, what we lay down in our developmental years is pretty much what we have. So this is a good kind of public health disclaimer for those younger individuals that we need to have a good, healthy, well-balanced diet and have a very active lifestyle as a younger individual. And that decreases our risk for osteoporotic changes as we get older. So by the time you get out of adolescence and into adulthood, you're not necessarily laying down more bone mineral density. You're just trying to maintain what you have. And you can do a better job at maintaining that higher level the more active you are, certainly. But it's hard to add to it at that point. So that's something important to remember for those younger individuals out there, and maybe for family members of yours to remind them of. And it's not all activity level, it's diet as well. But that's kind of beyond what we'll get into here. We're talking more about the risks once you have it and how to deal with it once you have that diagnosis. So when we look at that epidemiology, which epidemiology is a big word that everybody's heard more and more of here recently because of the pandemic. But basically that just means the the behavior of a disease through the population, how it works through the population. So generally, in people over 50 years old, 1 in 5 men and 1 in 2 women will suffer an osteoporotic fracture at some point in their life. You can attribute this to the fact that people are just getting older, living longer. Sure, yeah, that's part of it. The other factor here is that we aren't living as active as lifestyles, so our bone mineral density is declining more quickly because our activity level decrease, and we actually see that with when we drop down here to the comorbid conditions, diseases that limit mobility, Parkinson's, MS. There's no specific link to the having Parkinson's and the disease process, the physiologic disease process of Parkinson's, resulting in a lower bone mineral density. It's not like it inhibits our enzymes or osteoclasts, osteoblasts, things that change the makeup of the muscle. It's more so just that it limits your mobility, that then therefore limits your bone mineral density because you're not moving around as much. So obviously, if you don't have a disease of Parkinson's, but you are not moving around as much as we get older, which often many of us don't, then you're increasing your risk for breakdown in your bone mineral density as well. So that's important to be aware of. It's how active you are and how you're able to sustain that activity. Having rheumatoid arthritis, though, is a different factor. That in and of itself can increase your risk for fractures. So rheumatoid arthritis and some of those rheumatologic conditions can change your risk profile on their own without any change in mobility. Vertigo is an interesting one that I put on here, and I put it on here because this is something that has such a close relationship with balance, and it's something that physical therapists work with every day. So we have different types of vertigo that are out there, but the most common type, and the most common type I see in the clinic, would be benign paroxysmal positional vertigo, which basically means that you've got little crystals in your ears, in your inner ear, that get out and get through some canals, and then that can cause some dizziness as a result. That dizziness is a vertigo, so it seems like the room is kind of spinning and really challenging you, but it only lasts somewhere between 20 seconds to a minute. So that is something that becomes so much more common in those individuals as they get older. So it becomes more common as we get older, and one of the reasons is because those little crystals that are in your ears are actually made of calcium deposits, so basically like bone. And as your bone mineral density decreases with osteoporosis, the health of those crystals decrease as well. So then they can break off of each other a little bit more easily and get into places that they shouldn't be, and then cause some dizziness. So you can see again how osteoporosis could also kind of lead to more issues with balance, and then more issues with balance could lead to falling. So there's a lot of factors here playing in on one another. And that's why having a good workup and having a good understanding of your overall balance system and health of the body is important. So you might be wondering as we go through this, like, well, I'd like to know what my risks of fracture really are. And they actually have some nice tools that are available to help you with that. And I wanted to show you some of those. Let's see here. I think this will get us here. Let me just double check. Hold on. They have some nice tools that will help us along with that online. And then one of those is called the FRAX tool, which is basically just a fracture risk assessment tool. Okay. So if you can't see the new screen on Google Chrome, let me know. But all you have to do is type in FRAX, and it'll come up in any search. And you put in your information here. So age, date of birth, sex, weight, all of this information, history of previous fractures, history of familial fractures, currently smoking, glucocorticoids, those are steroids, and it will give you your risk for fractures at your age and demographics. So then you can make some decisions based on this. You know, my risk for fractures isn't very high, so I probably don't need to worry too much about some of these things that Colin's talking about right now. But if you do have a higher risk, then you need to start considering some ways to change your lifestyle and change your approach to how you're managing those risks. And as we scroll down here, we're talking currently about risk factors. And actually, this page does a good job on this table of outlining some of those risk factors. So all this information can be kind of described in here. You might not have something like the bone mineral density. You don't need that, like the femoral neck, number 12 there, the femoral neck bone mineral density. But that is helpful if you do have it. So that's something that's really nice for you guys, for everyone to be aware of using at some point if you are curious. So we're going to swing back over to the Word document. Now, I kind of covered this already, but expected increase over the next, there is an expected increase in fracture and osteoporotic conditions over the next 30 to 50 years, generally because there will be a predicted decrease in community level activity. So you can see again how the researchers that are looking into this emphasize how important it is to be active in these cases. So it's something that we need to be really aware of how we're being active, and we're going to get more into detail in that afterwards, but we need to really work into specific types of activity, and not all activities are created equal in that case. Before we do that, I want to talk about some common fracture sites. So the highest risk fracture site when it comes to osteoporosis is your hip. So hip fractures are associated with the highest risk of mortality and morbidity in the general population. I mean, it's something that really can't be ignored at this point, but if you have a hip fracture, then your risk, especially the older you are, your risk for not fully recovering is significant. Your risk for never making it back out of the hospital and is never making it back home is really, really significant. So you might end up in a long-term care unit. You might end up in even a higher level units. And some people simply just don't recover from the comorbidities that then are able to catch up by the time you're not moving. So oftentimes it's not necessarily the hip fracture that results in that downward slide towards morbidity or mortality, but it's that hip fracture that results in a significant reduction in your activity levels, and then all of your other comorbid conditions that you may be managing as you get older, high blood pressure, some different, maybe liver disease, some things like that, get a chance to really settle in and become and progress, and then that's what ends up resulting in the death of the individual. So it's something that cannot be ignored, and it's something that we really need to, from a public health perspective, be aware of, minimizing the risk for hip fractures, because it's bad news when it happens. Now, granted, there are individuals that bounce back really well, elderly individuals that bounce back really well from hip fractures, but it's just unpredictable right now as far as who is going to bounce back well. The thoracic spine is another second most common location for fractures. And you can see here, we can even see thoracic spine fractures with simple movements of bending over and lifting objects. So it's not necessarily a high impact activity that's causing it. It's just kind of increasing that pressure through that spine by bending through that spine. And as we get older, we can see individuals that are a little bit more curved forward, like we call it a kyphotic posture, where you're bent forward through the upper back. That could be posture, and that posture results in increased pressure on the thoracic spine segments, and then it can result in what we call like compression or burst fractures in those vertebral bodies. but also individuals may have fractures in the back resulting in that increased kyphotic curvature. So they can kind of cause that kyphosis, and they can also be caused by that kyphosis. So it's kind of like the hip fractures and the falling. One could cause the other one, and vice versa. But from a mortality and morbidity perspective, the thoracic spine injuries are not anywhere near as risky as the hip fractures. In fact, people usually recover from those conservatively and non-operatively. Sometimes, physicians will try what's called a kyphoplasty, where they will go in and try to shore up those spinal segments that are fractured. But from my understanding, it's not a super common practice. Then we can move on to the wrist fractures that basically occur maybe when reaching and like even lightly falling onto an object. You might not be falling all the way to the ground. You just catch yourself on something and result in a wrist fracture, which from the perspective of overall health and mobility isn't as big of a deal. But the thing is, it's going to kind of, you'll be limited with some dexterity and use of your upper extremity for a while, if not forever, if you don't get it fully recovered. Biggest thing to take from this is, again, these don't take big, heavy impacts to fracture, especially when you're pretty progressed with things. So you need to be aware of that. The diagnosis of osteoporosis is based on upon a bone scan. So it's your T-score, and your T-score of less than negative 2.5 would make you osteoporotic. Now, from -1 to -2.5 is osteopenia. 50% of fractures in females that occur, older females, I think it's above like 60, are linked to osteopenia, not necessarily osteoporosis. So just because you don't have the diagnosis of osteoporosis doesn't mean you aren't at an increased risk for fracture. So it's not like a binary thing where if you're not osteoporotic, you're good. And once you become osteoporotic, you're at a high risk. That risk starts when you have osteopenia. So once someone tells you have that, it's time to start looking at how you're moving around and how you're able to challenge your balance and challenge your strength in an appropriate way without putting yourself at increased risk. So that's something to be aware of. Medical management. So this is definitely outside of my scope of practice. I understand the intent of it, but I can certainly not consult people on one way or the other to go with this. But basically, I'll give you a quick overview. Starting at A there, the bisphosphonates, they are kind of the first line of intervention typically, and then it kind of goes down from there. So they're oral or injectable, and then you move down to that bone building medication down at the end, which is a little bit more aggressive. Now you think like, why wouldn't you want some sort of bone building medication at first? And the main reason is because the issues that come along with taking those are much more. So they have a lot more side effects that are more significant. So while they might be a little stronger in some ways, it's not worth it from the perspective of side effects. So those are always things to consider when you are considering intervening medically. Now, something that we know doesn't have too bad of side effects is exercise. Obviously, I'm biased towards this, but it's something that we can see called upon in the literature all the time for osteoporosis, amongst other things. But exercise is really important to consider in these cases. Now, we're talking, this first section here, Wolff's Law, is basically a law that says the more you use a bone, the denser it gets. So the more load you put through it, the denser and more healthy it becomes. Now, that Wolff's Law specifically applies to bones, but that's the general idea of how our whole body works in our bone and joint system, and even on to other areas of our body. And I think the easiest place to see this would be on our skin. We can see that if we slow, like I'm sure this weekend everybody was outside a little bit more because it was so nice, and you're using a shovel, you're using some hand tools that maybe you haven't used for a while, and if you don't have gloves on and you do a lot, you'll probably end up with a blister, which is basically what happens when we overload the tissue too much, too fast, and then it ends up becoming injured, tears and becomes injured. So that's equivalent to, in the bone, what a fracture would be. You're loading that bone too much, too fast, and that bone responds in a way that it just kind of breaks. It can't sustain that load. Versus if you say you knew the weather was going to be good this weekend 3 weeks ago, and you start just kind of using hand tools, holding them, moving around, and you slowly build that load and your skin's tolerance in your hand to it, so that this weekend when you're ready to go, you have a little bit of a callus formation, and you can do more with those tools. That's basically what happens in our bones too. We can build up that density of the bone to make it able to sustain those heavier loads without fracturing first. This happens in our muscle tissue, it happens in our tendon tissue, our ligament tissue, it happens in multiple tissues through our body. But the most important to us for the idea of osteoporosis is what happens in our bones. So we need to slowly build the load, but make sure we are consistently building the load. Now, there are, everybody talks quite a lot about weight-bearing activities being important for osteoporosis. And the most common weight-bearing activity that we see would be walking. Walking is something that is touted for its benefits across the board, cardiovascularly, strength, and all of that, and it's easily accessible to many. But unfortunately, walking has not been shown in isolation, has not been shown to modify the loss of bone mineral density as we get older. So not only does it not increase your bone mineral density, but it doesn't slow the loss of bone mineral density. So unfortunately, walking alone isn't enough, but that doesn't mean walking is worthless. That just means that with respect to bone mineral density, doing that in isolation is not enough. Now, obviously, we still recommend, on average, somewhere around 30 minutes of walking daily, but it's not going to just regular ground walking is not necessarily going to change things from a bone mineral density perspective. You need to make it a little bit higher intensity. You need to really try to load those tissues, contract those muscles a little bit more over that area. So the aerobic training that we're going to recommend in these cases would be a little bit higher intensity and with higher speed. This could be some running. It doesn't have to be sustained running. It doesn't have to be going out for a 10-mile run. You could do maybe running for 100 yards or 200 yards and then walking for 400 yards, something of that nature. If you're not into running, you could do climbing up hills. So, intentionally going up a steep hill, increasing that intensity, climbing up steps, and things of that nature. So trying to find some different ways to challenge the intensity is a really important thing when it comes to aerobic activity. It's not enough just to do that isolated walking, unfortunately. Now, the real key when it comes to osteoporosis and exercise is your strength/resistance training. So I see quite often when I have patients come in here that are older individuals, they really just don't like the gym, whether they're intimidated by it, they don't think it's worth it for them, whatever it is, they don't like going to the gym. And when they do go to the gym, they basically just go use the cardio equipment. I would love to change that. It's probably maybe one of my main drivers for doing these talks is, right, so just try to get some of this information out there that I have commonly have questions on, and then I can kind of stand on my soapbox here and try to at least get someone to listen to me. But if we could get people to use some resistance training some challenging resistance training more often as we get older, that would change things quite a bit from a risk factor perspective for issues even beyond osteoporosis. Now, the thing with the strength training is that it is specific to location. So if we have identified on bone scan that we have a decreased bone mineral density in our femur, like at our hip, then doing bicep curls isn't going to change what's going on at the femur. We've got to load through that femur specifically. So we need to do squats, we need to do leg presses, we need to do things like that to specifically load through that area. So we have to be specific, and it is something that can take a while to really get some benefit from. Unfortunately, you need to keep up with this for really like 3 times a week for almost a year to see some significant changes. So it takes some time, but what I would say is this is stuff you should be doing anyway. So it's going to benefit you in so many other ways that it's worth working into your routine. Now we need to make sure these exercises are progressing in challenge. So it's not that you just go put 45 pounds on the leg press and do it 3 times a week for a year. You need to make sure that you are making it harder while you're there. So we're going to talk about, I'm going to show you a program here at the end that's kind of an example program of how you can kind of go through this progressive program. But that's really important to remember. We need to progress the challenge. Just sustaining the same challenge simply isn't going to do it for you. You've got to progress and challenge. And that's one thing in physical therapy even that I feel is overlooked. When patients come in here, I don't think physical therapists traditionally progress people fast enough and challenge them enough. So when patients come here, we really emphasize making sure that their exercises are challenging and we're reaching for these goals that they have to maintain and gain and progress through to their goals. Another recommended type of exercise is balance training. So balance training in and of itself isn't necessarily going to increase your bone mineral density, but what it's going to do is decrease your risk for falls, because that's, we were talking earlier about how sometimes it doesn't matter how good your balance is. If your hip just fractures while you're walking, then you're still going to fall. But that doesn't mean that certainly doesn't mean we ignore balance training. And so I have another talk that we get more into detail on balance training, but that's something we cannot ignore. The vibrating platform is an interesting thing. Basically, it's a platform you stand on. You can do some exercises, squats and things, and it vibrates. I'm always hesitant as a physical therapist, or maybe it's just my nature, and skeptical, I guess is a better word, of like gimmicky type products. And this one seems a little gimmicky to me, but the evidence that I've looked into actually shows that there could be some benefit to doing that, even outside of the strength and resistance training. So what I would say is that having a good strength training regimen, having a good balance regimen, and then a high intensity aerobic regimen would be the top priorities for us. And then if we want to add in some vibrating platform training in addition to that, then that could only add more benefit. But doing just isolated vibration platform training might not really be worth it from what I've seen as of now. And that could change. Like I said, I'm always just a little skeptical of those things, because anything that sounds like it's too good to be true oftentimes is. So that's just something, maybe it's my own bias, but something to be aware of with that. So those are the kind of 4 general categories that you can approach from: aerobic, high intensity aerobic training, strength, progressive resistance training, balance training, and then vibrating platform training, which isn't just standing on the platform. It's actually sustaining some exercises while you're on the platform. So then I'm going to switch back to the Chrome. Yeah. Okay. So this is a program that was put together as a protocol for a trial that was done. And this table here illustrates the progressive nature of a strength training program. This protocol was, this trial was called Osteosize. So I guess it's specific to osteoporosis. And the idea is to build strong bones for life. So this program is a 12-month program. So you can already see, just like I said, they're acknowledging that it takes a while. So 12 months to work on this program. It's broken up into cycles, and within those cycles, there are kind of cycles. So there's these phases, 1, 2, 3, 4, 5, and then you have this first week in orientation at training, right? So remember, like what I was talking about, we don't want to throw you right into the lion's den right away, right? We've got to slowly build things up, and you can see we're kind of at a higher rep scheme here, a little bit, even with the high intensity stuff. Well, this RPE scale is rating of perceived exertion, and that's a 0 to 10 scale. 10 being something you can only sustain for maybe 10 seconds, whereas 0 is basically just sleeping. So we're at a 3 to 4. So not anything crazy from a resistance perspective. Your repetitions are higher, and your speed is slower. We do have high velocity progressive resisted training, impact focused exercises, and then functional training, which is kind of along that balance spectrum. But you see, as we go here, the RPE will increase, but it's not a linear increase. So it increases and then it goes back down, increases and goes back down, because we recognize that the body needs time to recover. So, I mean, this is basically how, if you're training for a marathon, we would create your training schedule. If you're an Olympic athlete, we create this training schedule in a similar way. Or if you're just trying to build some bone mineral density, we create it this way. I mean, it doesn't matter how elite you are, your body still needs a chance to recover. So that recovery is important to build in. That and being able to have this, you can see here where we're going. We do a few weeks with a certain level of challenge, and then we slow things down again. So we slow that speed. A few more weeks at a higher challenge with rapid, and then slow that speed down there. So, and with that reduction in speed comes an increase in repetition. So that higher rep, slower speed gets you to focus on the mechanics of the exercise, first of all, but then also gives your body a chance to recover. And then we'll challenge you with more repetition in a higher speed. So this program, I think, is well put together. There's by no means specifics. So this isn't something that you can just take to the gym and do it. This program has to be put together for you by a physical therapist or a highly skilled personal trainer to really put things together. And since looking more into this stuff, it's something that I have been kicking around with one of the other physical therapists that we have here at this office about trying to put some sort of program like this together to have for individuals to rely on. So that's something that we hope to, maybe we can even, if and once we do get it together, do a talk specific to that to help people understand what that means a little bit more. But these are a general outline of how we want things to go. Challenge, progressing, but not on a linear nature. And we want a good balance of high velocity, higher impact, and functional training exercise. So that's kind of what we would look to create for most people. And when people come in with osteoporosis at this point, we certainly do something similar, but we don't have anything that is like quite as large as like a 12-week progressive program, or 12-month progressive program, like what this is. So I think that could be something that the community could benefit from. Okay, so I am done generally with the talk, and I can swing over to the chat box, which I see Amy asked, is yoga beneficial? So that's a good question. If we think of it from the perspective of impact and load in bone mineral density, I would argue that yoga is probably neutral, right? It's probably not going to increase your bone mineral density on its own. it's, just like walking, I can't say if it's going to have an effect on minimizing the loss of bone mineral density. But if walking doesn't, then I'd be surprised if yoga would. The only difference is that yoga gives you an opportunity to weight bear through your upper extremity a little more. So that might help you. Maintain bone mineral density in the upper extremity better, because there aren't many cases that throughout our life otherwise that we weight bear through the arms. But what I think yoga would absolutely do is improve your balance and improve your body's awareness and body balance. So it's going to decrease your risk for falls because of the ability to maintain and improve your balance. So I think yoga is definitely beneficial, but maybe not necessarily for bone mineral density purposes. I haven't seen any studies though to tell me for sure on that one. Any other questions?
I'd also like to add, if you would prefer to ask your question out loud rather than through the chat function, you're welcome to do that at this point. We may not have that many for this session. I was curious, because you had mentioned the discrepancy between men and women in terms of osteoporotic fractures, and I'm sure that that's largely biological, but are there any other factors that play in there?
Right. So like the biological nature, postmenopausal women have a higher risk of reductions in bone mineral density for sure. The only other factor that I think would play in is that idea of like what you lay down when you're young is a good predictor of how you maintain density as you're older. I can't say that I've seen any studies, but especially years ago, especially the female's ability to participate in group sport activities, high intensity activities, was much lower than it is today, unfortunately. So that ability to participate in those activities probably did lead to less bone mineral density laid down at that time. So that's probably a factor in those individuals' ability to sustain. Now, I'm sure there's a study out there that I could try to look up on, the activity level of females when they're younger versus their risk factors as they're older, and that'd be interesting to look at, because I would imagine maybe there is a connection there.
Well, thank you. Any other questions that anyone would, I'm sorry, that anyone would like to ask? If not, we will wrap up for today. And the recording of this session, there might be a little bit of a gap in it. It seemed like we had a little skipping issue at one point, I think on my end. But the recording will be up by Wednesday evening. If you would like a copy of the handout, will that be available as well?
Yep. Yeah, I have to find the pictures and put them back in, but that's no problem.
Okay, you can email Dr. Gundling. You can email myself. I'm going to include my email address in the chat. So if you'd like that, just send me an email and we can get that out to you. All right.
All right.
Thank you very much, Dr. Gundling, as always. Very much appreciated.
Yeah, no problem. Thank you, everyone. Thanks for participating.
Thanks. Have a great day.